Hello, good evening. Today we are going to discuss our second session about perioperative care, eMRCS questions. We finished half of the questions a few days ago, and now we are going to continue the rest of the questions together. We will start by number, I think, okay, we'll start by 32. So now let's start with Dr. Mumtaz. Okay, can open your mic and start, Dr. Mumtaz.
Okay. A 32-year-old man requires venous access for chemotherapy. Groshon line, internal jugular central line, triple lumen, 14G cannula in the dorsum of the hand, 18G cannula in the non-dominant hand, subcuticular catheter. So I think it is internal jugular central line, triple lumen for chemotherapy.
For chemotherapy? No one has different answer.
Yeah. I don't know wrong line.
Sorry?
I don't know what is Groshon line.
Okay. Let's see the answer. In the dorsum of hand, no. Okay. I said that perioperative.
I don't know what is subcuticular catheter was.
Okay. Okay. For chemotherapy for chronic patients, we use what's named Groshon line or Hickman line. These are long-standing lines for giving chemotherapy for a long time. It has less risk for thrombosis, for pain, for blockage, for dislodgement or displacement. So they are mostly used in treatment of chemotherapy or giving medication for chemotherapy. You can check on Facebook. I always say, okay, good evening. Hello, Ms. Dr. Ghada. Okay, no problem. You're welcome. If you want to participate with us, you can raise hand. You can participate with us. Okay, you can. I always say in all part A, you have in all part A, you have to support your answer with Google Pictures. It's one of the main lines of studying. And not just to remind or just any answer you see and you don't know or you can't or you can't remember or you can't imagine, just go direct for Google, write your name or write the name of the procedure, write the name of the thing you don't understand and click image and see what is it. Anything, if you need to ask about indications of chemotherapy, clinical picture of acute myeloid leukemia, image all give you a simple, easy mnemonic to study. Simple, easy mnemonic to study. What's the difference between triple lumen and Groshon line? Okay. We have many things for giving many medications, whatever CVP, triple internal triple lumen. We give it in ICU. Sometimes we give it for something like what's called TPN, or some medications like albumin and something like this because it is less irritant. But for chemotherapy, we know. Okay, wait a second. Okay, I'll send now in the group what's the grossing line, so you can imagine. I sent on the group. Okay, this is tunnel track. Okay, it is tunneled caster, so you can keep it under the skin. Also the Hickman caster. Almost the same. Yes. Okay, so this is I sent in the group the crossing line and Hickman line. This is mostly tunneled caster, so it is available for giving long-term. Hello, Dr. Zafir. If you want to participate with us, you ready and you can raise hand.
Yes, I'm
welcome to our. This is crossing line. Okay.
Yes.
So Dr. Ghada also is ready. So we can Dr. Mumtaz, Dr. Ibrahim, Dr. Ghada, and Dr. Daf. Okay, so this is the difference between grossing line, Hickman line, and other lines, 14 cannula, and this simple lines for short-term IV medications or IV fluids. Again, I'm repeating that what I say every session. Please be simple, be attach it to the simple information they give to you. You don't need to go for more details. He just want you to know this name of the line. You will not find any other question about this line or how it is used, or what is the difference, or any other questions. Okay, just simply he wants you to know this name, so when you face it in your clinical life, you know what is used for. But if you find in every question you want to say 14G cannula and 18G cannula and subcutaneous caster and Intraoperative and grossing line and Hickman line, details about everything, your mind will be filled with information. You will be busy with many information. You are in need. You will find this sentence in many books, and so either online or hard books. You'll find eMRCS writing. This is out of scope of our study. Out of scope of our study. You have to keep your mind with 12,000, 2,000 questions, or 2,000 or 3,000 questions, which will be provided with recalls and eMRCS. So you can collect in your mind more and more about the 300 questions you will face in the exam. Please don't go out the scope of your study. Okay? Okay, tunnel, Dr. Ibrahim, means that you make a tunnel under the skin before you go direct to the vein or the artery you want to. Okay, so something like the tunneled drainage for the intracranial ventricles. Sometimes they make a tunnel starting from the neck and through the chest and the abdomen till they evacuate its content in the intra-abdominal fluid. It's something like tunneling the cannula or the catheter under the skin. Okay, we took long time in a question what he need from you, that he wants you that chemotherapy we give it in what's called Grossing line or Hickman line only. No need for more information to make your mind busy or know more about this. Okay. Okay, next question, Dr. Let's take Dr. Ghada first, because, and then Dr. Ibrahim, and then Dr. Daf. So ladies first, Dr. Ibrahim, I'm sorry for this.
Okay.
Okay. Just not to confuse with the turn. Okay, Dr. Ghada, تفضلي.
Okay. Good evening. Which of the following statements relating to the use of tourniquet in surgery is false? The use of S-mark bandage, a tourniquet is to accentuate the limb to reduce the incidence of neuropraxia. Excessive infiltration pressure are amongst the commonest cause of nerve injury related to tourniquet use. Tourniquet deflation causes a fall in
central venous pressure.
Central venous pressure, yes. Children requires lower inflation pressure than adults. In patients developing neuropraxia related to tourniquet, the radial nerve injury is the most frequently affected. So the faults, well, for children, yes, it's need lower pressure. Radial nerve injury and neuropraxia is common. With deflation, everything of parameters will need to fall in parameters. So it's either A or B, but the use of the bandage, I think this is the wrong one. The first option, it means if there's a bandage, there will be increase the incidence of a neuropraxia, not
exactly. The use of elastic bandage or S-marsh bandage tourniquet to accentuate the limb reduces the incidence. No, it gives the same incidence of neuropraxia because you are compressing the nerve as well. Okay, others by exclusion, you did it well.
Yes.
Perfect, very good. You did it by exclusion. It's nice. Yes, excessive inflation causes nerve injury. Tourniquet deflation causes fall and say central venous pressure. Yes, in children we need lower inflation. Patient developing neuropraxia most frequently affected. Radial nerve is most frequently affected. Okay. Next question, Dr. Ibrahim, تفضل.
In relation to patients with type 1 diabetes mellitus undergoing surgery, which of the following statements is untrue? They shouldn't receive oral carbohydrate loading drinks as part of enhanced recovery programs. When a variable rate insulin infusion is required, 0.45% sodium chloride and 5% dextrose with either 0.15 or 0.3 potassium are the fluids of choice. Hourly intraoperative blood glucose measurements are required. True. Insulin infusions are only required in patients who will miss more than 2 meals or who are nil by mouth for greater than 12 hours. blood glucose levels persistently greater than 12 should initiate a change in therapy. So between A and B, and I think B.
Why between they shouldn't receive oral carbohydrate loading drinks as a part of enhanced recovery program?
I thought it might be compensated by insulin.
This is
but
untrue.
No,
This is
it will
untrue.
cause-
This is untrue. Okay. A, let's take it by exclusion. A, you have a diabetic patient, type 1, okay,
Yes.
insulin dependent, and he's going for operation. Will you give this patient carbohydrate load pre-operative?
No, it will cause disturbance, hyperglycemia. So
Exactly.
I
So
won't.
it is true, they shouldn't receive oral carbohydrate.
Yes.
Okay, forget about the second one because this is, you should know, this is the regimen of giving fluids in diabetic patients intraoperative. You have to give insulin infusion is required. You give 0.45 sodium chloride plus 5% dextrose or 0.15 plus 0.15 or 0.3 potassium. This is according to the insulin level you will give because insulin causes hypokalemia. Okay. How are the intraoperative glucose measurement? Yes, and this is a protocol for diabetic patient intraoperative. I think we talked about this protocol last session. Insulin infusion are only required in patients who will miss more than 2 meals or who are nil per mouse per os for greater than 12 hours. Exactly, we talked about this and said you shouldn't miss more than 1 meal pre-operative. So whatever he missed 1 meal or 2 meals, more than 1 meal, you will go for an insulin infusion. In this patient, blood glucose level persistent greater than 12 should initiate a change in therapy. Yes, exactly. You are hourly intraoperative blood glucose measurement, and if you find it more than 11.6, exactly, I think 11.6, you should change your change policy and treatment. Okay, here is more than 2 meal. Insulin shouldn't be stopped in patients with type 1 on omission of more than 1 meal. Will usually require a variable rate of insulin infusion. Okay, Dr. Ayman Rashid, you want to ask or you want to? Okay, تفضل. Dr. Ayman, you raise your hand. Do you want to ask about anything or? Okay, so now I think we know the policy and we talked it about last time about how to deal with a diabetic patient. They shouldn't be admitted overnight. They should be early enlist. They shouldn't omit more than 1 meal. If you want to go for the morning list, you can just miss the morning dose. If in the afternoon list you can go for, or the evening list, you can just miss the dose before the operation. Blood glucose level should be monitored hourly in the operation room, and the regimen of fluid is 0.45 sodium chloride plus 5% dextrose plus the replacement of potassium. That's all about the diabetic patient, and this protocol should be done. I think this is a protocol for diabetic patient, and this is more important in part B. You'll be asked in details. Okay, next question, Dr. Dafer.
55 years old with no comorbidity due to undergo malignant Morgan hemorrhoidectomy. What is the most appropriate method of deliver immediate post-operative analgesia? Pudendal nerve release, caudal block, recent NSAID, rectal NSAID, intravenous fentanyl, paracetamol. So caudal block.
Caudal block, okay. Okay, I think we agreed. What about operation? We have a patient with hemorrhoidectomy, and you want to give a post-operative analgesia. Caudal block will be the best. We have the same question about an orthopexy for a patient or a child about, I can't remember, maybe 1 year or something like this. And you have to choose also a pain relief. We choose also caudal block. So we agree that if we need a post-operative perineal analgesia, caudal block, whatever he is, a child or an adult, will be the best choice for this. Okay, Dr. Ayman Rashid wants to participate. Okay, Dr. Ayman, go for the next question if you are ready.
Yes. Can you hear me?
Okay.
Hello?
Yes, okay, Dr. Ayman, تفضل.
Can you hear me? Can you hear me?
Yes. Yes,
A
yes, Dr. Ayman.
72-year-old man is from an hernia when he's CVA. He is managed on the rehabilitation.
Dr. Ayman's voice is unclear. You have a problem with connection.
Hello?
You have a problem with connection. Your voice is unclear, just interrupted. Can you just make your voice loud and read it again, please?
Yes, can you hear me now?
Yes, that's good. Yes, okay.
Signal is weak.
Yes.
No. Yes. A 72-year-old man is recovering from an inguinal hernia repair when he is suffer from an extensive CVA. He is managed on the rehabilitation unit. However, he's still not able to feed safely, and repeated swallowing assessment have shown that he tends to aspirate. Which one of the following best option for long-term feeding? It's a big tube feeding. Answer.
Okay, gastrostomy tube feeding.
Yes,
I think good for long term. Why we go for gastrostomy, jejunostomy if we have Dr. Skilled? Okay.
Skilled, yeah.
Need the B, feeding jejunostomy. But jejunostomy needs general anesthesia. Okay, I think we agreed about this last time. If I have a patient with CVA with a swallowing problem, I go for the proximal part of gut that I can access, okay? I have two parts of the gut I can access, okay? One is the stomach through gastrostomy, and the other one, the jejunum through jejunostomy. If I have problem in just only on the swallowing, I go for the gastrostomy. Why I go for gastrostomy? As long as you go for the most proximal part of the gut, everything about digestion and absorption and less complication for any feeding you will give, it will be less complicated and it will be mimic normal. As long as you go distally, like jejunostomy, you will face many problems in digestion, in disturbance, electrolyte disturbance, and flatulence, and diarrhea, constipation. You need more processed food, and not all food. You have less options for food for giving for the patient. This is different. In the stomach, you can give semi-processed food or unprocessed food and then give it in the stomach to go. But as you go for the jejunostomy, you will be restricted with some types of food, with some types of processing food, and you will have more complication. As long as you go distally, you will have more complications in your feeding process. So if I just have a problem with the swallowing, why I go for jejunostomy? Why I pass the stomach? I have the stomach, as long as the esophagus is intact, I can access the stomach for feeding, okay? Okay, again. I have here the oropharynx, then I have the esophagus, then I have the stomach, then I have the duodenum, then I have the jejunum. Okay. I have a problem here in swallowing. Esophagus is intact, so I can go for gastrostomy. Okay, tube gastrostomy. Less complications. You can give food as you can, even it is undigested food. More easy accessible through the epigastric area. Operation most commonly in this patient can be done under local and infiltrating anesthesia through the rectus sheath, and it's much more easy than going for jejunostomy. Okay, but if I have a problem in the esophagus, for any cancer esophagus, if I have patient with cancer esophagus, I'm not talking about patient with CVA. This patient with the blue is patient with CVA and problem with the swallowing, so I can go for gastrostomy. But if he told me a patient with perforated esophagus, Burhave esophagus, or cancer esophagus, or achalasia, and he done operation or something like this, I can't go for the stomach because it will be a risk of aspiration and regurg through the chest, and this will be a big problem. So I have to bypass the stomachs to the jejunum, okay, to make a jejunostomy, and it's more time-consuming operation and more risky operation, and has more complication with displacement, and frequent displacement of the tube is very common, and also you are restricted for some food, okay? When we study in part B about surgical nutrition, you will know that every place you can give certain food. When the nasogastric tube, you can give certain food. You can't give big particles because you're afraid from blocking from the tube. If you go for feeding gastrostomy, okay, you can give anything you want, no problem, even it is undigested food or semi-digested food. When you go for the jejunum, so you pass the stomach, you pass the duodenum, so you passed a big process of digestion, so you will be restricted for semi or almost more near total digested food, as you're giving it to the jejunum directly, not to avoid complication of digestion, complication like diarrhea, constipation, flatulence, and ileus that may happen if you give undigested or semi-digested food. So there is some restrictions with feeding jejunostomy about food and the operation itself. So as long as you find the stomach accessible for you, okay, you can go for gastrostomy, okay, if the esophagus is free. If the esophagus is not free, you have to go for jejunostomy as a second option for you, okay? And we said before, less than 2 weeks, you can go for any tube feeding like nasogastric tube, or nasojejunal tube, or nasojejunal, some nasojejunal tube, no problem, okay, as long as you are going for short-term feeding. But more than 2 weeks, or sometimes here he don't want to confuse you, sometimes he tell you more than 1 month, you need feeding more than 1 month, okay, or the patient is not expected to be back normal soon, and he wants you to tell you it is a long-term feeding, you have to go for the surgical feeding, which is through the gastrostomy or jejunostomy tube feeding, percutaneous gastrostomy or jejunostomy feeding option. Is it clear?
Yes.
Anyone can't understand, I can repeat it again, no problem. Okay. Okay, next question, Dr. Mumtaz.
Okay. A 57-year-old man is coming off the cardiac bypass circuit following a successful coronary artery bypass procedure. Which drug should be administered to normalize the patient's clotting prior to decannulation and chest closure? Intravenous vitamin K, protamine sulfate, aprocitentan, fresh frozen plasma, none of the above. It's protamine sulfate. It will.
Protamine. Okay.
Because it acts against the unfractionated heparin. I think. Yeah.
Exactly. Patient.
Heparin.
Yes. Okay. Patient going to cardiac bypass or any cardiac operation. These patients are fully heparinized, and as soon as they finish the operation, the patient should be back to normal by protamine sulfate, which is antidote for heparin. And we said that pharma questions we know by names, we know as it is. Protamine sulfate is the antidote for heparin. Okay. Dr. Omar. Dr. Omar, you raise hand. I think you are not activating your mic. Dr. Omar, please activate your mic and then we raise hand. Just you can ask or you can write in chat. Okay. Okay. Next, Dr. Ghada, تفضلي.
A 34-year-old man is suffering from septic shock and receives an infusion of dextran 70. Which of the following is complication may potentially ensure? Anaphylaxis, vomiting, acute hepatic failure, digital necrosis, deep vein thrombosis. Anaphylaxis.
Exactly. Dextran 40 and 70 are very famous with anaphylaxis. Okay, so it is not avoid septic shock, by the way. And also this is the same idea of colloids. The same idea of any colloid. Why you don't give them in septic patient? Okay, because in septic patient they have. Okay, تفضل.
Due to risk of anaphylaxis.
Okay, they have anaphylaxis, and the second thing, in septic patients there is a capillary dilatation, and these colloids may escape through the capillary pores and may accentuate the septic shock and the hypotension. They can go outside the capillary and increase the oncotic pressure and the extracellular extracellular region to absorb blood from the intravenous or the intravascular space outside the vessel to increase or accentuate the process of shock. So in the first day or second, or in the first few days, except for blood, sometimes they give it. But other than colloids, they are not preferred to given for septic patients early in their septic shock. Okay. دكتور إبراهيم تفضل.
A 70-year-old man with a past history of angina undergoes an uncomplicated operation for a hydrocele. Post-operatively, he is found to be hypotensive, tachycardic, and has a raised jugular venous pressure. What is the most likely explanation for the hypotension? Reduced stroke volume, reduced parasympathetic tone, reduced preload, reduced sympathetic tone, reduced afterload. We have here raised jugular pressure, so the preload is high, so C is wrong, and the afterload also has no relation, and stroke volume has no relation with
What is the big problem of tachycardia? Patient with AF or tachycardia, what is the big problem with this patient?
little stroke
What
volume.
will exactly? Patient with AF will have less stroke volume.
Yes.
This stroke volume or incomplete evacuation. So this patient
Yes.
will have congested preload.
The high end
Congested.
diastolic volume and congested. Yes.
Okay.
Then,
Most blood
the
coming from the
explanation.
systemic circulation will
Yes.
not be completely pushed or pumped by the heart because of the tachycardia, and this is also the problem of AF also as well.
Okay.
Okay.
Yes. But how can we understand there is AF from this question?
I'm saying the same. He didn't say AF, but he said tachycardic. But we said as long as the heart will be fast, the stroke volume will be less.
Okay.
He has a history of angina as well.
It is not. Also, it has. So you here we suspect this patient with starting cardiac failure or starting bundle branch block or something like this. So the patient has a problem with pumping the blood. So he has tachycardia and hypotension. And tachycardia is a response for the hypotension. Is a physiological response to hypotension. So low stroke volume means low afterload. Yes, low afterload, exactly. So it is low afterload, not low reduced preload. Okay. So this patient will have a cardiac problem that happened post-operatively due to anything, because this patient already has an angina and has a cardiac problem. So he will start to be hypotensive, and tachycardia will be as a response for the hypotension. Okay. In answer, sorry. Low stroke volume mean low afterload as well. But in the answer, you have reduced and reduced afterload.
Yes.
Reduced sympathetic tone. Okay.
So the patient suffering from the hypotension, tachycardia, and raised GVP. This is mean on failure. So during the failure, decreased stroke volume, increased contractility, impaired contractility, and reduce the stroke volume and decrease cardiac output. What is the mean cardiac output? Cardiac output equal stroke
volume and the rate.
And the rate. So the rate high, but the stroke volume will low. And during the
exactly, this is the starting of impaired contractility or heart failure.
Yeah.
This is a problem. Reduced sympathetic tone. No, the problem here is the cardiac.
Yes.
Patient, he is taking a patient with a history of angina. He wants to tell you post-operative, take care of this patient, that this patient has a cardiac problem, and mostly post-operative, if you found this patient hypotensive, tachycardic, and raised jugular venous pressure, exactly, raised jugular venous pressure, so the patient, the heart can pump the whole amount of blood coming from the body. So this patient has this problem. You have in part B in details how to manage a cardiac patient perioperatively, the same like diabetic patient. how you'll manage a patient cardiac, how you'll manage a patient with mitral valve stenosis, how you manage a diabetic patient. All this is very important, big topics in the part of critical care or applied surgical science and the critical care in part B. Very important volume, very important topics in details. Here, you just need, if you want to tell you, if you found a patient with a history of angina post-operative in the world having this problem, you have to doubt a cardiac problem. Okay? That's the idea he wants to tell you in this patient. Don't go for details, keep details for part B. Okay, you will have much more. You know what? Okay, so why do we pick reduced stroke volume and not reduced afterload?
This is the good question. Afterload mean, can I explain for that?
Okay, doctor. Go, Dr. Dafir.
Yes. The afterload, it's mean the tension on the blood vessels. So if it's reduced, it not causes the increased JVP. So for that, it's excluded.
Okay. You have the definition of afterload.
Yes.
Okay. In part B, it is, you know the definition, Dr. Dafir?
Yes.
Okay, what's the definition exactly? Because it is a very important question in part B.
Yes.
And it has been asked to me also as well. Okay?
Yes, the definition, it is the load of the blood, it is the load of the blood on the wall of the vessels. This is the afterload.
Okay, keep it more accurate.
Yeah.
It is the I can write the power of, I wanted to say this is the effort. This is the effort needed by the heart to open the aortic valve against the blood in the aorta.
Yes.
This is afterload. The effort needed by the blood, by the heart, to open the aortic valve against the blood in the aorta. This is the afterload. This is an effort. This is not an amount. By the way, the preload, the amount of blood. The preload, this is the amount. You can go for Google and write definition of afterload and definition of preload. Preload is the amount of blood will be pumped with the heart, will be pumped, which will fill the right atrium, which will fill the left ventricle. Okay? And the left atrium and left ventricle to be pumped to the body. But the afterload is the resistance will be met by the heart to pump the blood. This is two definitions, by the way, we found it. It is the resistance will be met by the heart, by the left ventricle to pump blood against the peripheral vascular or against the blood in the aorta.
Yes.
Okay, this is the afterload, by the way. So there is no reduce in the afterload. Afterload here is not an amount. Afterload means a resistance.
Yes.
Will be made by the heart. Okay, doctor? It's clear, Dr. Skill. Okay, you will understand it more if you go what is the definition for the afterload and reload. Go for both definitions and you will understand the difference between the preload and afterload. Next question. Who's Dr. Dafir?
Yes. In relation to intervention in elderly, which statement is false? 30-minute increment in operation length association with the increased mortality in patient over the age of 18. The hypoalbuminemia is association with the increased mortality. This is false. Statin give a preoperatively reduced preoperative cardiac event. elevated brain or B-type nitrate, NBN, elevated level before undergo non-cardiac, just a minute to listen, non-cardiac surgery is associated with the highest cardiac mortality and all-case mortality. Beta blocker should be stopped acutely prior to surgery due to risk pre-operative hypotension. I think so. It's false. Beta blocker should be stopped acutely prior to the surgery due to risk of pre-operative hypotension, but I'm not sure.
Exactly. Even it is biologic. I said that questions that which of the following is false and which is following is untrue, which is following is true about. This is the most silly question you will face in the exam, because it will be want you to read everything to say right or wrong, right or wrong. But here, sometimes the question is very clear. Did you go for any operation and abruptly you stop any medication before, especially cardiac medication?
No.
I think so. Beta blockers shouldn't be stopped acutely prior any surgery. Shouldn't be stopped acutely prior any surgery. Patient on beta blocker and you stop acutely, you stop the medication pre-operative, I think they will have many risks in the perioperative period and perioperative care. Okay. Some questions are clear. You feel like the author can't write it right. He write in sentence. He write any answer to make it wrong, and so okay. And you find it's unlogic, sometimes silly, sometimes funny answer.
Believable from the easier one.
Yeah. But I'm with you. Most questions, which of the following is false, which is untrue about, it is somewhat silly question in the exam, and it's make you read all the questions. Sometimes questions you search by your eyes and your mind about the answer, as he want to tell you what is the name of the classification of this fracture.
Yes.
You go by your mind searching about this classification, but answers that he wants you to read all the questions. This is the silliest answer in the exam and the silliest question in the exam. Okay. Just why I always say, don't keep the 40 seconds or the 1 minute for question, because some questions will take from you 5 to 10 seconds, and some question will take more than 1 minute really, to save time for these questions. Okay, next question, Dr. Ayman, تفضل.
Yes, doctor. Which of the following intravenous fluid solution has the greatest chloride content?
From its name.
Normal saline.
Exactly, normal saline. Saline has the highest chloride content, followed by the Hartmann or Ringer solution. Here is simply, if you can remember, okay, the saline has 135 and 135, okay, and the Hartmann has 130 and 110. This is the most you have to know, by the way. Don't need to know more than this. If you ask it in the exam, you'll ask Hartmann has 130 and over 110 plus potassium, okay, and this is why it is preferred in shock patient or patient with hemorrhage or patient with severe vomiting or diarrhea. You have to give a Hartmann solution because it has all the minerals, including potassium, but normal saline and has the same sodium and same chloride in its concentration. Okay, keep both these in your mind only, Hartmann and normal saline. Okay, next question. Dr. Dr. Mumtaz again.
A 5-year-old boy undergoes a closure of a loop colostomy. What thromboprophylaxis should be used? None. Daily low-dose, low-molecular weight heparin for 2 weeks. Daily low-dose, low-molecular weight heparin until discharged. Unfractionated heparin and compression stockings. Oral dabigatran for 4 weeks. I think it's none because it's a low-risk surgery. Its age is less, and also only it is reversal of loop colostomy. So it's low risk. So you don't need any thromboprophylaxis.
Exactly. We give low molecular weight heparin or whatever heparinized patient for patient with high or moderate risk according to this patient. But patient with no risk, no need to give him any prophylaxis for blood anticoagulant or blood thinners. Okay, next question, Dr. Brian, تفضل.
A 43-year-old lady with a metallic heart valve had just undergone an elective para-umbilical hernia repair. In view of her metallic valve, she is given unfractioned heparin pre-operatively, peri-operatively. How should the therapeutic efficacy be monitored, assuming her renal function is normal? Heparin is monitored by ABTT-B.
Okay. Exactly. Monitor heparin by unfractionated heparin should be therapeutic efficiency monitored by APTT perioperative. Okay. Okay, next question, Dr. تفضل.
Patients receive atropine as a pre-medication prior laparotomy. Which of the following is likely to occur? Pupil dilatation, dry mouth, urine retention, bradycardia, decreased salivation. So atropine giving to treat the bradycardia anesthesia, so it is not cause the bradycardia. Hi.
Yes, sorry. So
atropine, it's giving to patient to avoid the bradycardia, so it is not cause the bradycardia during anesthesia. So I choose the bradycardia.
exactly. Sorry, I just have a phone call. Okay, all of us know the side effects of atropine, yes?
Yes.
I think it is known with the word red. Everything is red or R. Flushing, tachycardia, mydriasis, I think.
Yes.
And dry mouth.
The dry mouth.
This is
it means decrease the salivation, so it is okay.
Exactly. So this is the problem of atropine. Okay, tachycardia, dry mouth, flushing, and pupillary dilatation. So I think with the word D.
Yes.
Dilatation, red, dry mouth, and tachycardia or rapid heart rate. This is a problem. So bradycardia, it is not a problem with atropine. Okay, next question, Dr. Ayman, تفضل.
Yes, can you hear me?
Yes. Yes, Dr. Ayman.
Hello? Yeah. A 72-year-old man is due to undergo an inguinal hernia repair. He suffers from COPD and has an exercise tolerance. of 10, he also has pitting edema to the thigh. What is his ESA? So we have comorbidity, we have inguinal hernia, and we have, I think, cardiac failure. So it's 5, I think.
It's 5. Can you remember the ASA?
ASA is 5.
No, can you remember the ASA?
No, but you said last time. I remember the one it was without no mortality, without anything, and 5
no comorbidities.
Yeah.
Number 2.
Yeah, but the 5.
5 is the patient you should give. Okay, keep 5 for the patient. You have to do an operation once within few minutes, within 1, 2, 3 hours. If you didn't the operation, he will die. And this will give you operation like internal hemorrhage, spleen rupture, or abdominal aortic aneurysm. Mostly the question will talk about abdominal aortic aneurysm rupture or splenic rupture. This is a patient number 5. Okay, so this is a patient with mostly accidental acute injury. This is number 5. The patient, if he didn't do the operation now, he will die. Or patient with severe extradural hemorrhage, traumatic extradural hemorrhage, the patient will die if he didn't do the operation now. This is number 5. Okay. Number 1, the patient has no comorbidities. Normal patient, 25 years old, going to do a herniotomy or a hernioplasty. This is number 1. Number 2, patient has controlled comorbidity. Controlled comorbidity. Patient has hypertension, but he is controlled. He is 45 years old or 50 years old, and he is controlled hypertension on simple medication and so on. So this patient has comorbidity, but controlled. So no problem. You can go for number 2. Number 3, patient has uncontrolled comorbidity, uncontrolled hypertension, or uncontrolled diabetes. Okay. So this patient go in the category of number 3. Okay. Number 4, patient has a problem or comorbidity that constantly threatens his life. And you are talking about constant threatening his life. So we're talking about patient with heart failure and manifestation of heart failure, and he should do an operation like obstructed inguinal hernia. So this patient is constantly have a problem that threatening his life. Or patient has COPD, a severe COPD, and patient going in some sort of respiratory failure, and this patient constantly threatening his life by severe COPD he have. This is number 4. So exclude number 5. This is mostly acute patient with sudden incident like a trauma or rupture of spleen or rupture of abdominal aortic aneurysm. And go from 1 to 4 like this: normal, controlled, uncontrolled, threaten his life. What is the category here?
It is 4. So we have cardiac failure,
COPD,
and we have
COPD and cardiac failure and pitting edema. So the patient has a problem that constantly threatens his life. Again, because you will have 1 or 2 questions about ASA scoring system in the exam. You will have 1 or 2 questions. Okay. Number 1, he will give you a normal patient, which mostly will be 1, 2. I don't remember, but it's for me in my exam came 1 and 5, by the way. Okay.
Doctor, and for the surgery.
Sorry.
Hello. I mean,
yes,
and the number 4, grade 4, the surgery doesn't matter, or should be?
No. Surgery patient. We're talking about this is for anesthesia. You are giving a patient to anesthesia. You consult the anesthesia for a patient. You want to do an operation. In which category the anesthesia will put this patient? Okay. Sometimes if in your clinical
Okay.
work, you go for anesthesia and give him a list. How the anesthesia can
Yes.
prioritize this list or order his list? According to this, you'll tell him, I have a child with hernia and I have a cardiac man with thrombosed anal piles. So he will take this patient and tell me, please, I want an echo for this man. And I want to make this man like cardiac enzymes. And I need cardiac consultation. And if the cardiology write for him some medication for 2-3 days or any intervention procedure, he will go. This is the category. The consultant of anesthesia will put the patient in this category. He just put some cups in front of him and he put every case in the cup. So number one, no organic, no physiological, no biochemical, nothing. Okay.
Yes.
Okay.
Just
Number
I
one,
understand now.
nothing. Okay. Nothing. Number one, the patient is completely normal patient. Number two, mild to moderate systemic disease. Will not intervention. Okay, you went to the anesthesia, and what is the problem with this patient, Dr. Ibrahim or Dr. Ayman? This patient has controlled hypertension. Okay, let him stop his morning tablet for hypertension, and after the operation, he can go back to take it immediately. So he will not care about this patient. Number three, has a severe systemic disease. Severe, but not threatening his life. Not threatening his life. Okay, he has uncontrolled hypertension, uncontrolled diabetes. He has COPD, but without complication like pitting edema, respiratory failure, or anything else. Number four, patient has severe systemic that constant threatening his life. Patient has complicated systemic disease. Complicated systemic disease. Okay.
So he may request ICU bed for this patient or like this.
Yes, and he want to prepare this patient more and a good preparation for this patient before the operation, and keep in the theater cardiopulmonary resuscitation equipments and defibrillator and DC shock and many precautions should be done in the intraoperative theater, in the OR, for this patient. And this is also, you will study in details in part B, how to be ready for a patient, cardiac patient or diabetic patient, intraoperative. What should be prepared for this patient? Should be prepared 1, 2, 3, 4. Okay, Dr. Ibtihal.
Yes, I have a question.
Okay, تفضل دكتور Ibtihal.
In this patient, he is a COPD patient with bilateral pitting lower limb edema. Where is the threat to life in this condition? I think
this is a patient
with ASS class 3, a severe systemic disruption caused by pre-existing disease. Why is
tolerance?
This patient?
Yes, the exercise tolerance for 10 yards.
Exactly. This is very severe and constantly, and the patient has a heart failure.
Yeah.
The patient has a pitting edema up to the size. You can imagine.
Okay. I'm sorry. Yes.
And 72 years old. Many parameters here in this patient. He's 72. He's COPD with exercise tolerance 10 yards and pitting edema.
Yes. Okay.
I'm sorry, this patient is dying intraoperatively until proved otherwise.
Yes, exactly.
Okay, I'm sorry for this.
This is true.
But yes.
هيطلب
So
منك
this patient, okay, this patient is a high risk consent up to this pre-operatively.
Yes. Okay.
Even in UK. Okay.
Yes.
Even in UK. I'm sorry for this, but this is true, and this is safety for you.
This is
any
true.
patient.
No any surgeon do the inguinal repair unless obstructive for this case.
Exactly. Okay, next question. Whose turn? I forget. I think we'll start again with Dr. Momtaz.
A 53-year-old alcoholic male presents with acute pancreatitis. He is clinically dehydrated. His blood results show normal renal function and electrolytes. Which of the intravenous fluids below should be prescribed? 0.9% sodium chloride and 40 millimole potassium chloride, 5% dextrose, Hartmann solution, 10% dextrose and 20 millimole potassium chloride, 5% dextrose and 40 millimole potassium chloride. It should be Hartmann solution.
Exactly, Hartmann solution. The patient has a third space loss.
Yes.
Okay, because of acute pancreatitis. So this patient should receive the most close, the most solution close to his normal plasma levels of electrolytes, which is the Hartmann solution. Okay. Okay, next question, Dr. Ghadat, تفضل.
Just waiting for the screen.
Okay.
Okay. Yes. Which of the following agents is least suitable for a 23-year-old man with burns and bilateral tibial fractures after being trapped in a car accident for 2 hours? Dexamethasone, atracurium, vinacurium, panicurium, propofol. Well, in case of burn, there will be hyperkalemia. So dexamethasone is contraindicated, right?
Okay.
I think it's dexamethasone, first option.
Perfect. Just keep in your mind not to confuse with some question like put this word. Okay. This is need in exam stress, and you are solving about 120 or you are solving 180 question. This word is very important to look. It's least suitable.
Yeah,
okay. Okay. Because you can go for propofol, you can go for this. You are taking which is the following is suitable for 23. No. Take in your mind about this one. About these words because it's very important. Okay, dexamethasone may induce hyperkalemia, so it is not indicated in patient with fracture or patient with already mostly has hyperkalemia. Okay.
Yes.
I think dexamethasone causes some muscle twitch, and this is, by the way, this is the sign by the consultant of anesthesia to know that dexamethasone started to work. Okay, he looks to the patient as long as started to find in the cheek or in the eye, starting to have, or in the mouth, some twitches happen. So now he is fine to intubate the patient and go for this, and go to complete his operation. Okay, this is a sign you have to look to the patient during giving dexamethasone.
It causes also malignant hyperthermia.
Malignant hyperthermia because I don't know if someone of you did see a patient has a deficiency in cholinesterase deficiency.
Yes, I have.
Will be I did see it twice. You will be it is a nightmare for any surgeon or a nightmare for any anesthesia consultant or something like this to see a patient with cholinesterase deficiency or malignant hyperthermia, and it has now it is maybe one, and you can find this one in about 6 million person, and it has no medication, and patient mostly will die This is the malignant hyperthermia. The cholinesterase deficiency will make the patient delay in recovery up to 3, 4, 6, 7 hours. This patient, sometimes intubated. This patient, by the way, if you see it once in your life, you'll never forget. Okay.
I saw too.
I did see it twice, really. A patient after the operation, he can't, no recovery up to in the morning list up to 4 o'clock in the afternoon, in the evening. No, nothing.
Yes.
And
They
no
died or
recovery.
what?
And no, pass the patient good, but he has a cholinesterase deficiency, which catalyzes the succinylsonium, and the patient can has a good recovery and smooth recovery. Okay, but this patient has deficiency, so it will be late recovery, very late recovery, up to 6, 7, 8 hours, maybe 1 day, or something like this. Put in your mind also, muscle relaxant, succinylsonium is the only depolarizing one. Others, or atracorium, ficronium, or pancronium, all of these are non-depolarizing neuromuscular blockers, by the way. Okay.
I have a question.
Okay.
What is used
Dr.
to
Montel.
reverse the action of succinylsonium?
Sorry, again.
What is used to reverse the action of succinylsonium?
Succinylsonium.
Yes.
Dantrolene.
Antidote?
Dantrolene.
Dantrolene,
Yes.
intravenously.
Dantrolene, yes.
Dantrolene, exactly.
Okay.
But I think it's not available in the practical.
It is catalyzed itself, and the patient starts recovery normal. But dantrolene, this is in this problem, patient with cholinesterase deficiency or malignant hyperthermia, and it is not available. So, by the way, and most, I know many doctors went for medical legal problems because of malignant hyperthermia in patient like this. Okay, put in your mind also depolarizing patient, succinylsonium, non-depolarizing all the other muscle relaxant. Okay, Dr. Abdul Qadir, تفضل.
Yes,
Okay, you want to ask or you want to participate?
I want to participate.
Okay, so whose turn now? Dr.
Abdul Qadir.
Yes, me.
Dr. Ibrahim. Okay, so Dr. Ibrahim, Dr. Dafer, Dr. Ayman, then Dr. Abdul Qadir. Okay?
Okay.
Okay, Dr. Abdul Qadir, thank you for your participation.
Thank you.
Okay, Dr. Ibrahim, تفضل.
A 63-year-old man is recovering following an open extended right hemicolectomy for carcinoma of the colonic splenic flexure. 2 days post-operatively, he develops persistent pyrexia. What is the least likely cause? Ileus, atelectasis, anastomotic leak, wound infection, UTI. It's ileus. Ileus doesn't cause pyrexia.
Exactly. Least likely cause. First time I read this question, I didn't read least, by the way. So I said that atelectasis, anastomotic leak, wound infection, urinary tract infection, all these can cause. When I back to the question, I found least. So ileus is the least cause that may cause pyrexia in this patient.
And sorry, Dr. Elias, does it take time to appear or to minister? Elias, is it take time to manifestation on the patient or maybe directly after
He's just thinking about Elias. No, Elias may happen post-operative, immediate post-operative. The patient stay maybe 1 or 2 days without passing, and you find the patient has Elias. And you have to search about the problem, but it doesn't cause fever.
Yes,
Elias
right.
doesn't cause fever. Okay. but you can find it in the patient. You find in the ward at the same day of the operation, the patient didn't pass, and there's still no intestinal sound. The same next day morning, and so on. So you have to search for the problem. Is it equilibrium balance? The patient has any problem inside? Many problems about ileus. You have to search about uremia, about failure, about anything, but it doesn't cause fever, post-operative fever. Next question.
A 72-year-old man is due to undergo an esophagectomy for malignancy. His BMI is 17.5. What is the best feeding regimen immediately following surgery? Yes, I guess the answer should be feeding jejunostomy.
Okay.
Is it right?
Why didn't go for soft liquid jejunostomy? Okay. He is not mentioning here gastrostomy, but here is the most appropriate feeding option is the feeding jejunostomy. Yes, exactly. I think Dr. Daffer didn't
Yes,
answer.
Dr. Ayman.
Okay, Dr. Daffer. Dr. Ayman, تفضل.
Daffer, finish?
Yes, for you.
Yes,
Yeah.
yes, Dr. Ayman.
What is the most what is the most appreciated management for a 56-year-old lady who has shooting pain in her arm following a mastectomy and axillary node clearance? Diclofenac?
This is a neuropathic pain, yeah?
Yes, neuropathic, of course. She's shouting.
Shooting pain, this is a neuropathic pain. And we agree last time about what is neuropathic pain and what is the options of treatment of neuropathic pain.
Yeah. Neuropathic, there was pregabalin and the other one imitriptyline or like this.
Exactly. Neuropathic pain. We said amitriptyline. Okay, but it causes orthostatic hypotension as contraindicated, but most questions in the exam you'll find pregabalin. Okay. Most questions in the
was
exam
about
you'll find,
yes, the last.
you'll find pregabalin. Okay, and we said we have two exceptions. We confused about one last time, but I make sure from it. Diabetic, neuropathic pain, what we will give?
Duloxetine.
Exactly. And we make sure about trigeminal, neuralgia. What we choose?
Carbamazepine.
Carbamazepine. Okay, keep this in your mind. Neuropathic pain, amitriptyline, but it causes orthostatic hypotension or contraindicated patients with orthostatic hypotension. But we go for pregabalin, and most questions in the exam will talk about pregabalin because it's the most famous in the market. Yes. Okay, and it has a special regimen in giving and 50 and 100 and 300 and something like this. The other one is diabetes mellitus. We give duloxetine, and the last one is trigeminal neuralgia. We give carbamazepine. Clear?
Okay.
So in case of the amputation due to diabetes mellitus, we give amitriptyline or dilexine.
Here you have the option pregabalin. If amitriptyline, you can go for amitriptyline, but he will not give you both of them. Sorry?
You said for exception for diabetes mellitus, we give dilexine?
Diolextine. Diabetic neuropathy?
Dilexine.
Diolextine. Diabetic neuropathy. Diolextine. Okay.
So, I mean, if we for example, we do amputation for.
This
for
is
a
neuropathy
patient,
for amputation. You give
pregabalin.
Pregabalin. What amputation for a diabetic patient? You mean?
Yes.
Okay.
Yes,
who are you
yes,
want to confuse yourself with this question? Who are you want to confuse yourself? Maybe this pain is neuropathic pain due to the amputation. It is due to neuroma at the site of neuroma or site of surgery. So it will go for pregabalin. But if it is a neuropathic pain and away from the site of surgery, so it will be diolextine, and he will not confuse you by this question. He will not confuse you by this very sophisticated questions, okay?
Okay, fine.
So this is pregabalin, okay? I think next will be Dr. Dr. Mumtaz. Dr. Abdul Qadir, you want to ask about anything? Dr. Abdul Qadir?
He want to participate.
Okay, Dr. Abdul Qadir, we take it by turn. Dr. Mumtaz, Dr. Ghada, Dr. Dafir, Dr. Ibrahim, Dr. Ayman, then Dr. Abdul Qadir. We take it in turn, okay?
Yes.
Okay, thank you, Doctor.
Now turn Abdul Qadir, I think.
No, now turn Dr. We'll start from again, Dr. Mumtaz or Dr. Abdul Qadir?
Now Dr. Abdul Qadir, I think.
Yes,
okay,
yes, I want to. Yes, sir. So
Okay.
I have a question about the previous.
Okay, Dr. Abdul Qadir, تفضل.
Yes, sir. I have a question about the previous topic. Basically, I gave exam. So there was a question about the pain management. Okay. So that was quite confusing. They gave two questions separately in the same paper, in the paper 2. The condition was the same, a minor trauma, and which causes flail chest on the right side, and what will be the treatment you will give for this condition for a young patient and for an older patient. They gave only oral NSAID and then IV diclofenac and a local anesthetic agent. Somehow I remember these 3 options only. So that was quite confusing for me there, because on the young patient what we will give, and for the older patient, a 60 or 65-year-old patient, what we will give for the flail chest. It's a recall question. I gave that exam that I failed by 8 numbers.
I think flail chest we give, anyone can remember what we give for the flail chest? It's a very famous question.
Okay.
Dr. Dafir, you can remember?
Flail chest?
Yes.
Type of analgesia?
Yes.
It is the NSAID. I suspect, I guess.
You suspect what?
I guess the NSAID.
NSAID.
Non-steroidal anti-inflammatory drugs, yes.
No. Flail chest mostly they give sometimes they give nerve block. No. Sometimes they give morphine. The patient has a respiratory compromise already.
No,
you
basically
can't give morphine.
Basically,
sometimes what I can remember that sometimes something like epidural analgesia, and sometimes it's nerve block, intercostal nerve block.
Okay.
Selective intercostal nerve block. I'll search for you about this, but I can remember it in the cardiothoracic trauma.
They don't give any nerve block or any option. My confusion here is that what about the age? in the young
What's his
patient,
age?
one question was about 25 years young patient,
Yes.
and another question was about 65 years old patient. The condition and the stem are same. So my question is, what will be the appropriate treatment for this flail chest in the young case and also in the old case?
I think in the old case you can give intercostal. When in both of them they didn't give you any intercostal block or something like this.
Okay.
For flail chest, epidural analgesia.
Epidural analgesia.
Yes.
Epidural. Okay. Okay. Thanks a lot.
Okay.
Thanks a lot, sir. Okay.
I think I can remember something like epidural or nerve block.
I get it.
As far I
You get it now?
that, as far I remember, they didn't give any epidural analgesia on that option.
But I think I had this question before, and they give epidural analgesia. I think so.
Yes.
I can just check now.
Both questions came at April 2019.
Sorry.
Both questions came at April 2019 eMRCS Part A. I gave that attempt basically, which is why I'm asking.
Just a minute. Okay, I'll get it from the book of the eMRCS website after the Zoom. Okay, I'm just trying, but I think the website is very. Yes.
Okay, sir.
Okay.
Thanks a lot. Thanks a lot for your kind consideration.
Okay. Because I know exactly that I this is a question I faced before here. Yes, maybe also in recalls, but epidural or intercostal nerve block, both of them is accepted. Okay, so here's whose turn? I forget. Who's now? Start again, Dr.
Abdulkader. No.
Dr. Abdulkader. Okay, تفضل.
Okay, sir. I'm continuing the screen question.
Okay, this is
yes, 38 year. Continue.
Continue.
Okay.
Yes.
Yes.
A 38-year-old lady present with abdominal pain. On investigation, her serum calcium is found to be 3.5 millimole per liter. What is the most appropriate initial management? It should be intravenous bisphosphonate.
What's the first line of management?
Most appropriate initial intravenous bisphosphonate.
This case is a case of.
I can't see me.
This is a case of hypercalcemia.
Yes,
Okay.
hypercalcemia.
What is the
Okay.
first line of management of hypercalcemia?
It should be intravenous bisphosphonate.
No, this is not the first line of treatment.
So,
This is the third line even.
oh,
You have to rehydrate the patient. Rehydrate the patient. First, you have to give normal saline, and it's a very first line you have to mention in Part B exam when he tell you patient with hypercalcemia, what is your management? As you mentioned, I'll give IV normal saline, then he will stop you. Okay?
okay.
Okay, IV normal saline. Plus, by the way, they give furosemide, but he is talking about the most appropriate initial management. Okay, all these can be given. Bisphosphonate, okay, can be given, but initial management, you have to rehydrate the patient immediately with normal saline. Then you can give furosemide, and so think about other causes, and you have to mention treatment of the cause but there is first line general management and then specific management for the problem. Okay.
Okay.
Does the sodium chloride lower the calcium level? Or
It is
just
rehydration for the
illustration?
patient. He will tell you good rehydration for the patient by IV normal saline. And then continue your medication about this one. Okay.
Okay.
This is guidelines for treatment of hypercalcemia.
Okay.
Intravenous fluid resuscitation. Complementary. Then he say immediate treatment is
Intravenous
intravenous
0.92
resuscitation. This complemented by bisphosphonate, sometimes diuretics, give furosemide, and so on. This is the first line of treatment.
Okay. Okay, thank you, sir.
Okay. Next, we'll start again. Dr. Mumtaz, تفضلي.
The following are contraindications to the use of lignocaine for local anesthesia, except accelerated ilioventricular rhythm, current maker, severe sinoatrial block, protein C deficiency. It should be protein C deficiency. That is not a contraindication because it doesn't have any relation with lignocaine. But all the others are heart problems, so you cannot use it.
Okay. Exactly. All are contraindicated except. Okay. Except protein C deficiency. Number 4, Dr. Ghada, تفضلي.
A 43-year-old lady has undergone a total thyroidectomy for multinodular goiter. You are called to see her because of respiratory distress. On examination, she has a marked stridor. Her wound seems healthy, but there is a swelling within the operative site. What's the most likely explanation for this problem? Bilateral superior laryngeal nerve injury, hypocalcemic tetany, anxiety, contained hematoma, unilateral recurrent laryngeal nerve injury. There is a swelling at the operative site, so it's a contained hematoma. D.
Okay. D, it is a contained hematoma. Exactly. Mark Strider, the wound seems healthy, but there is a swelling at the operative site. This is contained hematoma. If he didn't mention it and he mentioned and the wound is sound and clean, so you will go for
Strider nerve injury.
Nerve injury. He will give you nerve injury. He will not bilateral superior. No, he will give you recurrent laryngeal nerve injury.
Yes.
Or inferior laryngeal nerve injury. Okay. But as he mentioned, this is 2 questions are very important. Sometimes he tell you the wound is clear and sound, and sometimes he tell you the wound has swelling, so it is a contained hematoma. Another question, he will tell you the patient with massive multinodular goiter or retrosternal multinodular goiter, long-standing, large or retrosternal multinodular goiter, and after the operation you found the patient with a stridor. What's your
Laryngomalacia.
laryngomalacia? Exactly. This is the most common 3 questions you'll face about stridor post thyroidectomy. One with contained them. Sorry?
Tracheomalacia.
What did she say? Tracheomalacia.
Yes, because she
Laryngomalacia. She said laryngomalacia.
Okay, no, tracheomalacia. Okay.
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 Sorry.
Okay. Tracheomalacia. This is the most common 3 types of question you will find post-operative or post-thyroidectomy, stridor in patient or difficult breathing in patient post-thyroid operation. Next question. Okay, Dr. Ibrahim.
An 83-year-old man is admitted for an abdominoperineal excision of the colon and rectum for a distal rectal tumor. His comorbidities include diabetes. His renal function is normal. What is the best form of thromboprophylaxis? Non-compression stockings alone for 4 weeks. Daily low-dose, low molecular weight heparin for 4 weeks. Daily high-dose, low molecular weight heparin for 4 weeks. Daily administration of high-dose unfractioned heparin until discharge. Between B and E.
B, compression stocking 4 weeks. You will make the patient
not logic.
with compressed. It is not logic, yes.
It's
So
intraoperative only. We will give heparin, but
okay, you will give low molecular weight heparin. Okay.
Yes.
You will not give unfractionated heparin. Let us agree about low prophylactic. We give low molecular weight heparin, and the prophylaxis for low molecular weight heparin, we give it
low dose.
We give low dose for 1 time daily. The prophylactic is once daily. Okay, we give low dose prophylactic. Why not C? It's C, right? Yes, low molecular weight heparin. The high dose we give it as therapeutic. The low dose we give it as a prophylactic. The dose of heparin, of unfractionated heparin, is very special. The enoxaparin. Sorry, I think someone has background. Okay, especially enoxaparin. We have the dose of the patient. Keep it in your mind when you're giving Clexane or in low molecular weight heparin, especially enoxaparin. If you're giving therapeutic dose, you will give the weight of the patient twice daily. The weight of the patient, almost, you have the concentration in the market 60, 80, 40, and something like this, 40, 60, 80. So if the patient is about 60, 65, something like this, you can give 60 milligram twice daily. You give the dose of 60 twice daily. If the patient is 80, you give 80 twice daily. Because the dose is 1 to 2 milligram. It's about 2 milligram divided in 2 doses. 2 milligram divided in 2 doses. And the prophylactic, you'll give it once, and from 0.5 to 1, according to the age, according to comorbidities, and you can give, maybe you can give 40, you can give 60, you can give 80. If the patient is more than 80, you can give 0.5 to 1 milligram per kg per day on 1 dose, once daily. This is the prophylactic dose of low molecular weight heparin. So low dose of low molecular weight heparin. High dose, we give it in therapeutic patients only. It's clear?
Sir, in the low molecular is it contraindicated in renal impairment?
Low molecular weight is contraindicated in impairment.
This question I'm asking.
Yes,
Yes.
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 You should have normal renal function. And he will mention this in the exam. He will mention it in the question, in the scenario. And the patient has a normal renal function. Okay. But if he mentions that the patient has about the impaired renal function, you'll go for heparin.
Unfractionated heparin.
Unfractionated. Okay. Next question, Dr. Daffer.
Yes, a 6-year-old child long-term drug therapy to treatment a rare genetic disorder. The drug must be given intravenously. Recently, there have been issues with the child pulling at a current system of Hickman line, and the parents are request an alternative. What is the best option? Triple lumen subclavian line, porta catheter device, intermittent cannulation as needed, peripheral intravenous catheter, central catheter line, provoke line. I choose intermittent cannulation as needed. C.
Intermittent cannulation is needed.
Yeah.
It's an alternative for Hickman for a patient
Because
taking long-term therapy.
Yes.
Okay, anyone has different answer?
Oh, portocath device, I don't know.
Yes, portocath. I think it's portocath.
Portocath is the most common device used for patient long-term therapy for chemotherapy and
For chemotherapy.
genetic. It's very, very common, and portocath you can't see any line outside. This is a subcutaneous capsule. Subcutaneous capsule. It is in the most left subclavian place or subclavian area. Okay. And you just feed it like a pumping capsule, and you can inject any injection inside it, and you have nothing outside the body, nothing of the device and outside the body. This is implanted by a surgeon, okay, after cannulation of the subclavian vein.
Yeah, Doctor,
Okay.
you have sent two pictures in the group.
Yes, the same, by the way, like Hickman and this. I did see it twice or 3 times with oncologists. Yes, this is a device. You just feel it by your hand, like a button, but it's soft rebound button, and inside this cavity, and you can direct pull the needle to inject any medicine you like to.
And the picture, this Hickman?
You have not. I sent Groshing and Hickman, but portocath anyone can send it if you please. Just search in Google and send it. Portocath is very common device, subcutaneous tunnel device for giving long-term medication.
Okay, so what is there different as therapeutic to choose the vein or no? For example, this Hickman in
Hickman you have Hickman and Groshing and the Broviac. These have some sort of tube. You'll find a tube, or the line is outside the body. Some line outside the body. You can pull it or something like this, but it is the portocath is completely hidden under the skin. Completely hidden under the skin.
Yes, I know portocath. I have did it many times in practice. But Hickman, I think it used for dialysis more. For dialysis.
Yes, dialysis and sometimes long-term medication. The same, or long-term procedure like dialysis. Hickman, portocath, and Okay.
Okay.
All other options here are lines. You can't make intermittent cannulation. You can't use a line, peripheral induced catheter line or Proviac line. All these lines, the same, the child will have a problem pulling them, but Portcas will be the most suitable one. Okay, next question. I think Dr. Ayman, then Dr. Abdul Qadir.
Yes, doctor. 45-year-old man with the previous phlebotomy is admitted with adhesion small bowel obstruction. He is managed with prolonged nasogastric drainage. His electrolytes are as follow: sodium 129, potassium 3.4, urea 8.4, creat 89. Which of the following intravenous should be prescribed? So we have we have to give
this patient has two problems here.
Yeah, he have obstruction, means he need resuscitation. So we give Hartmann for resuscitation.
Again.
There is, he has obstruction, means he has adhesion, means he dehydrated.
What about the
electrolyte is
electrolytes?
about normal. So sodium is low.
Sodium 129 low, and potassium is low.
Yeah, low. So we
low sodium and low potassium. So you should give sodium and potassium.
Yes. So
higher than normal, you have to
sodium
give
chloride with yes, and as well the patient vomit lost potassium, so we give sodium chloride with 40 millimole potassium chloride per liter.
Exactly.
Right? Yes.
We will give 0.9 sodium chloride with 40 millimole potassium chloride per liter. Okay, we want to replace this patient has hypokalemia and hyponatremia, so you'll give both the sodium and the chloride as well, and potassium as well. Hartmann normal. We said Hartmann is normal or near have the same normal electrolyte or mimic the normal plasma. So you are giving something normal plasma, the same. But here we have hypo. We need to give higher. We have to replace the deficit. We have to replace the deficit.
I think.
Okay,
yes.
go.
Yeah, I think in this patient they expect that the patient will lose more potassium because of the obstruction.
Exactly. This patient has now patient has hyponatremia and hypotony. You have to buffer the intracellular stores, as he said here. You have to buffer the intracellular stores. You have to give higher than normal. Higher than normal, so the patient can buffer the loss or the deficiency and then back to normal. And you are giving this in precaution. You're giving potassium in precaution with following the patient with electrolyte analysis. The patient is normal, you will stop. The patient is losing, you will continue in a baseline or in a normal rate or in a low rate, just buffering the loss of this patient. Okay, this is an ICU work, critical care work. Found the patient is about 4. Okay, continue. Next day is the patient is 3.8. Okay, give again and stop. The patient is going down, so the patient has a continuous loss, so you can give a baseline of 40 millimole per day or something, or twice daily or 3 times daily. You can give potassium as long as the patient is in need. Okay, ICU work. Dr. Abdul Qadir, تفضل.
Okay, thank you, sir. A 55-year-old man requires a flexible sigmoidoscopy to investigate bright red rectal bleeding. What is the most appropriate preparation? Single phosphate enema the day prior to the procedure, single phosphate enema 30 minutes pre-procedure, oral sodium picosulfate the day prior to the procedure, oral sodium picosulfate 30 minutes prior to the procedure, rectal lavage with saline 1 hour pre-procedure. I think the answer should be single phosphate enema, but there is a dilemma. It should be prior to the procedure or 30 minutes pre-procedure. As investigate for the red rectal bleeding, I think single phosphate enema the day prior to the procedure.
Okay, so you choose
I choose
D,
number 1, single phosphate enema the day prior to the procedure.
the day before the procedure.
Yes, single phosphate enema the day prior to the procedure.
No, we agreed about this last.
Okay, as bright red rectal bleeding investigation, so it should be 30 minutes pre-procedure.
Certain, we agreed about this. When we are preparing for colonoscopy, we start the preparation 1 day before, okay, by purgatives, okay, and laxatives. But if we are going to do a sigmoidoscopy, we'll go for just phosphate enema 30 minutes before the procedure. Only 30 minutes before the procedure.
Okay, thank you, sir.
Which is just basic. Again, we revise again.
Okay.
Forget about the first one. Okay, the ERCP, you have to do an clotting and vitamin K if the patient is jaundiced. But the most important you will face in your practice or in part B about the diagnostic OCD in a case of communication skill.
Okay.
He will tell you, the patient will ask you during the communication, what about should be fasting, when I stop eating, when I stop drink, and something. You tell him 6 hours before OCD, and by the way, he can up to 2 hours can drink water, no problem. Up to 3 hours can drink any water, no problem. Okay, but about food should be fasting. Flexible sigmoidoscopy. Sigmoidoscopy will go 30 minutes phosphate enema before the procedure, 1 day before colonoscopy, 1 day before the operation. He will continue in oral purgatives the day before the operation. Okay, and will be all 6 hours NPO before.
Okay.
What about chewing gum? Okay. This is the most important. 3. By the way, if the patient is old age or has comorbidities, you have to check urea and electrolytes before giving purgatives, because it causes some sort of electrolyte disturbance. Okay?
Okay, sir. Thank you, sir.
Yeah, okay. Dr. Rada asking, what about chewing gum? I think this is not allowed, Dr. Rada, because it's most the GIT to secrete the GIT secretion and the fluid, so it will be like same fluid, but up to 2 hours before any fluids, no problem, because it will be expelled outside the stomach before the procedure. I think. Do you have any answer or any problem with this question, or did you face it with someone? For how many hours should be postponed?
Okay.
Postponed about what?
Sorry,
You,
if a patient, yes, if a patient was chewing gum and we
yes,
discovered just before the operation. So
2
for how many
hours.
hours? 2 hours or 6
2
hours?
hours. 2
Why
hours. No,
2
chewing
hours?
gum 2 hours. And we are
Okay.
talking the new protocols. We are doing if he drinks some water, up to 2 hours, the patient is allowed to drink water, except
Yes.
for obstructive patient. Patient has
Yes.
special conditions like obstruction duodenum or pyloric obstruction or something like this, or patient has paralytic ileus or slow movement of the GIT or something like this. But normal patient going for the operation, you can up to 2 hours before the operation, he can drink water. And the gum is the same. It is just producing oral and esophageal and gastric secretions, normal secretions, and it's fluid in nature. So
Yes.
within 2 hours, it will be completely fine.
Okay.
Okay. And I think patient going to an operation and he chewing gum is any
There was a question
fun.
somewhere, I remember. Yes, there was a question, but I don't know where.
Yes.
About chewing gum.
Okay,
Yes.
maybe. I think I did see this question, but it was maybe in practice or something like this. And when some patients tell you till when before the operation I can have one cigarette. I don't know exactly what.
This question was there in past test actually.
During what?
This question is there in the past test.
I think
bank.
so.
Past
Yes,
test?
somewhere.
Past test about
Yeah.
chewing gum?
Yes,
I
yes.
think.
We always say that past test is, for me, it's much more difficult and it's preparing you for FRCS.
Yeah. Yes.
Past test is much more harder, by the way. And if you start with past test, I'm sure 50% of candidates will stop studying eMRCS. So I always advise my friends and our candidates, start with eMRCS and go for recalls. You will add some question and you'll find many questions the same as eMRCS, and then end by past test. So you can continue or not, or you just can read it one time to take just the difficult and different question you didn't face before and put it in your mind or write it down in any place and so on. For me, in my exam, I just studied past test in paper 2 one time, and in revision, I couldn't revise again. But because it's disappointing.
Yes,
And by the way, I get more than 88%, 88.4 on only eMRCS and recalls. Okay, I'm not telling you many questions, by the way, from past tests come in the exam, but I could solve maybe from recalls and from because recalls are much more important. The basic is eMRCS. Recalls to strengthen your is recalled is the basic for any exam you go in your life. You have to choose the experience of any exam, but the basic which will prepare your mind how to think about the question is eMRCS. Past test, even its questions, it's fold. You need about 1 minute to read the question, because the question is 2, 3. The scenario is long scenario, and each answer is long, 1 or 2, or sometimes 3.
You have to read the option, because you will understand the question from the option.
Yes.
Exactly. No, until now I don't know why past tests. But many when they go, they tell that past tests have some question about 20-25 question, and I think you can bypass past test. But don't say that I said bypass past test. If anyone can go for past test, it will strengthen. It will power the second paper 2. It will make it more powerful. For part A, please don't go for past test. It's already enough physiology. Anatomy, no new questions in anatomy is past test, because anatomy is anatomy, okay? But in physiology and pathology, I think they are enough confusing to add more confusing questions for them. Paper 2, okay, no problem. You can go for. Just read it once or twice to see what is new ideas they want. But in long scenario question, make sure in the exam there is no longer question. Most questions are very short scenario and short questions. You may find 1, 2, 5 questions in the old exam with long scenario. Okay. Next, who is ready? Doctor. Who was last one who reads the question?
Now I think Mumtaz there.
Okay, Dr. Abdul Qadir. Okay, Dr. Mumtaz. Okay.
Okay. Woman presented to the emergency department with a large fluctuant swelling at the site of a recent insect bite. She is anxious, tachycardic, and pyrexial. An ECG shows atrial fibrillation. She is noted to have a goiter. The swelling at the site of the bite requires surgical drainage. Which of the following classes of drug would be most appropriate as part of her preoperative preparation for surgery? Alpha-1 adrenoreceptor agonist, alpha-2 adrenoreceptor agonist, alpha adrenoreceptor blocker, beta adrenoreceptor agonist, beta adrenoreceptor blocker. So in this question, I think she has hyperthyroidism, because of which it leads to atrial fibrillation and anxiety and tachycardia. So for hyperthyroidism, we use beta blocker.
Beta blockers, exactly. Without reading the question, the beta blocker is one of the preparatory medication we give for a patient hyperthyrotoxicosis or hyperthyroidism preparing for operation. Beta blockers is one of the basic medication we have to give for this patient. Okay. Beta adrenal receptors blockers. Okay, next question. Dr. Ghada.
Sorry, which of the following drugs is not positively inotropic? Dopamine, glucagon, thiophyllene, sodium thiopentone, dobutamine. Sodium thiopentone. It has cardiac side effects.
Okay, this is a pure pharma question. Dopamine is inotropic. Glucagon, thiophyllene, and dobutamine. Dopamine and dobutamine are direct cardiac inotropics. Glucagon and thiophyllene has some inotropic effects, but sodium thiopentone no. Okay. Next question.
28-year-old man undergoes a laparotomy for perforated duodenal ulcer, and the broad-spectrum antibiotics are administered. Post-operatively, he has hearing impairment. Which of the following agents is most likely underlying culprit? Gentamicin, cerebrofloxacin, metronidazole, ampicillin, cotrimoxazole. It's gentamicin. A.
Okay, gentamicins are known by ototoxicity. All aminoglycosides, by the way, are known by their ototoxicity. And the most common of them is gentamicin. Okay, next question. Dr. Rafir.
Yes. 62 years old lawyer has a transurethral resection of the prostate which took 1 hour to perform. The ST2 contact you as the patient has become agitated. He has a high heart rate, 105 beat per minute, and its blood pressure 170 over 100 millimeter mercury. He is a fluid overload. His blood result reveals sodium of 120 millimole per liter. What is the most likely cause? It is D, over administration of the normal saline. It's not. Syndrome inappropriate antidiuretic hormone. It's not. Congenital cardiac failure. Not. Is transurethral resection prostate syndrome? Yes. Acute renal failure. It's not. So it is D.
Exactly. This patient has a TURP syndrome. It's the most common problem that happens after transurethral resection using glycine hypotonic solution in the irrigation process using glycine. Okay, put this in mind. Glycine. This is a hypotonic solution used for irrigation for during transurethral resection of prostate, and this is causes hyponatremia, and also it causes hypervolemic hyponatremic problem in patient going for this operation. Now this why they use this? Because he was using before the unipolar electrode in this process, but now while using the bipolar, they can use normal saline or other solution, normotonic solutions that don't cause this problem. Okay, this is because you will ask it about this. And this is dilution hyponatremia and fluid overload due to glycine toxicity. And by the way, glycine toxicity also absorbed by the causes brain edema, and some of the confusion because of the brain edema caused by the glycine. And also glycine is converted in the liver to ammonia and causes hyperammonemia, causes also the confusion and many problems with glycine. And now they stopped using glycine after using the bipolar electrode in the resection of prostate. They can use normal saline or any other normotonic saline as well. I don't know if anyone on urologist here with us. Anyone urology? If anyone urology will know about this. Glycine now stopped used, and they are using
normal saline.
Normal saline and using the bipolar electrode by the way. Okay. Next question, Dr. Ayman, then Dr. Abdul Qadir is the last question. Dr. Ayman, تفضل.
55-year-old man undergoes an appendectomy through a lower midline rhabdotomy incision. What is the most appreciated modality for providing postoperative analgesia? We give we can give patient controlled analgesic infusion.
You will give the patient laparotomy
infusion.
You will give him morphine.
Yes.
Okay, exactly. Post-laparotomy. We prefer just to give the patient midline incision. We give the patient patient-controlled analgesia as an infusion or PCA. Okay, it's mostly contains some sort of low morphine dose and controlled by the patient and controlled by the device as well. Last question, Dr. Abdul Qadir, تفضل.
Okay. A 73-year-old man is recovering from a stroke, but is deemed to have an unsafe swallow. Apart from his cerebrovascular accident, his past medical history includes rate control atrial fibrillation and a previous esophagectomy. What is the best option for long-term feeding? Okay, endoscopically inserted PEG tube, surgically inserted PEG tube, surgically inserted feeding jejunostomy tube, TPN via peripheral venous access system, and TPN via central line. Though I guess TPN via peripheral venous access system.
Sorry.
D, number D, TPN, total parenteral nutrition via peripheral venous access system. Or it could be surgically inserted feeding jejunostomy tube.
Only feeding jejunostomy tube. There is nothing in the scenario talking about TPN. Okay. This patient has a problem in the esophagus. So he wants a little bit to confuse you. When you saw CVA, you go direct for gastrostomy tube. Okay. You go direct for gastrostomy tube. So here he won't tell you a medical history include a previous esophagectomy. If it is unsafe to go for gastrostomy, it is unsafe to go for gastrostomy. And we said if you have a problem in the esophagus, you should go for the jejunum to do jejunostomy. Okay. And the difference between here, even here, he want to confuse you by endoscopic percutaneous gastrostomy or surgical insert percutaneous gastrostomy. Both are the same, and this depends on the patient condition, how to do, which one to choose, and this is out of scope of our even scenario here, or even in your study. He will not ask you about when to choose endoscopic or surgically inserted, but he wants to tell you a patient has a problem in the esophagus, cancer esophagus or esophagectomy or operation in the esophagus or perforated esophagus. You can't go for gastrostomy, unsafe for the risk of aspiration. So you go direct for feeding jejunostomy. Feeding jejunostomy. Laparotomy is so simple, oral anesthesia won't reduce the pain.
Okay, thank you.
In practice, by the way, laparotomy we go for oral analgesics or IV analgesics, no problem. We don't, PCA is not very common post-operative for most patients, by the way. We give PCA for very high operations, or like sleeve gastrectomy or big laparotomy for transplantation, or big operation like Whipple and something like this. But normal laparotomy, it is uncommon in our countries. I'm talking about our Arabian country to give PCA, except for big operation. I think we finished. Okay, exactly. Okay, thank you.
Thank you so much, sir.
For your participation. Thank you all. Any question? We'll go to close. Thank you, Dr. Laila. I think Dr. Laila first time with us.
Thank you very much.
Thank you, Dr. Mumtaz,
thank you very much, sir.
Dr. Dafer, Dr. Ayman, Dr. Ibrahim, all who part, Dr. Abdul Qadir, all who participate with us today. Thank you so much.
Thank you so much to you, sir.
And wish I could help you. We finished perioperative, and we prepare within 2 or 3 days to finish another new branch. I'll stop recording now.
Okay. Take care.